شاء الله بندوة جديدة أعتقد أنها على قدر كبير من الأهمية الكريتيكال نيوتريشن. هيسعدني ويشرفني أن يكون المودريتور بتاع الندوة النهاردة 2 من eminent بروفيسور دكتور إيهاب خيري، بروفيسور of Pediatrics and Nutrition, Head of Clinical Nutrition جامعة عين شمس كلية الطب، والبروفيسور الدكتورة حبيبة قلبي وصديقتي دكتورة حنان إبراهيم، زميلة الكفاح ورئيسة وحدة الرعاية المركزة، والقائمة بالمجهود الأعظم والأوفر في تنظيم هذا المؤتمر الصعب تحت كل ظروف وكل المعاني التي لا يستطيع أن يقدرها أحد من مدى المجهود الغير طبيعي بذلته الدكتورة حنان حتى تستطيع أن تجعل هذا المؤتمر على هذا القدر من الجودة الحدود الإمكانيات المتاحة في هذه الظروف. فطبعا أحب أوجه خالص الشكر للدكتورة حنان على نشاطها، وأوجه خالص الشكر للدكتور إيهاب خيري على تشريفه لنا. وليتفضلوا.
Thank you, my dear professor, my mentor, Professor Dr. Tarek Abdelgawad, for this nice introduction. I am really honored to participate with my dear friend. Many years ago, we started the work together as residents. Professor Ihab Khairi, the head of Nutrition Department, Pediatric Department at Shams University. I think Dr. Ihab will introduce the first speaker. Please, Dr. Ihab.
بسم الله الرحمن الرحيم. طبعا برحب بيكم وحضراتكم جميعا، والله كلكم وحشتونا جدا جدا جدا. يعني الواحد نفسه، يعني مش عارف اقول ايه، كل حد فيكم الواحد نفسه يشوفه ويقعد معاه، لانكم فعلا كلكم وحشتونا. شرف كبير ليا اني اكون النهارده مودريتور للجلسه العلميه السادسه في مؤتمر الرعايه المركزه، وحده الرعايه المركزه لطب الاطفال جامعه عين شمس. الحقيقه المؤتمر هو كل سنه متميز، وكل سنه في تميز عن السنه اللي قبلها. الحقيقه النهارده المره دي يعني انا حضرت كتير جدا، يمكن 80% من الجلسات اللي فاتت امبارح، وبتاعه الراديولوجي وبتاعه الكوفيد 19 وكله. الحقيقه مجهود رائع وخرافي الحقيقه، يعني من استاذي واخويا الكبير الاستاذ الدكتور طارق عبد الجواد، واختي العزيزه على قلبي جدا. انا هغير لو الدكتور طارق قال حبيبه قلبي، ما انت حبيبه قلبي يا حنان برضه، احنا هننسى حبيبه قلبي طبعا. دكتوره حنان بدايات عمري في طب الاطفال كانت معاها، اشتغلت معاها وانا نائب جونيور، وطلعنا مع بعض في فتره النيابه كلها وكمدرسين مساعدين، ويعني سنين عمر معاها. والدكتور طارق شخصيا درس لي في الراوندات، كنت بروح احضر له كتير قوي. يعني شرف كبير ليا اكون معاهم. النهارده موضوع مهم جدا، الكريتيكال نيوتريشن في البيدياتريك انتنسيف كير، ومعانا الحقيقه 4 سبيكرز على اعلى مستوى هيتكلموا عن النيوتريشن ان انتنسيف كير. وانا في الاخر خالص هقول هاو، يعني بعد ما هم يوروا لنا اهميه الكلينيكال نيوتريشن في المرضى بتوع الانتنسيف كير، هايلايت على حاجه مهمه جدا، على هاو تو سكرين for malnutrition in patients, hospitalized patient، بالذات البيشنتس اللي في الاي سي يو، علشان نقدر نبيك اب early nutritional problems ونعالجها. It's my great honor to introduce the first speaker, one of the eminent professors of pediatric clinical nutrition في مش عايز اقول في الميدل ايست كله، مش بس في مصر، ويمكن اول واحده حصلت على ماستر الكلينيكال نيوتريشن في مصر. هي الوحيده من طب الاطفال عندنا اللي حصلت على ماستر الكلينيكال نيوتريشن، واول واحده فعلا تحصل عليه في مصر. وانا بعتبرها دينامو وعقل مفكر لوحده البيدياتريك كلينيكال نيوتريشن. اختي الفاضله والعزيزه على قلبي جدا، واللي الحقيقه برضو زي الدكتوره حنان معايا، كانت هي بقى النائب الجونيور اللي معايا، اختي الفاضله الاستاذه الدكتوره مي نصار. يعني اكيد هنسمع منها احلى كلام، وهي النهارده هتتكلم عن المايكرو نيوترينتس ودورها في المرضى بتوع الانتنسيف كير. انا رجائي بس لكل البانل اثناء التوكس احنا كلنا نقفل المايك ونقفل الفيديو عشان ما ياثرش على الارسال بتاعنا. دكتوره مي اتفضلي، احنا عندنا 25 minutes، تنورينا وتشرفينا ونسمع او نستمتع بالمحاضره الجميله بتاعتك. اتفضلي يا دكتوره مي.
Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, I'm overwhelmed. Thank you for the kind words, Professor Ihab. Thank you, Dr. Hanan, for the kind invitation. I'm honored to be here with you tonight. And I asked to talk first, although I'm gonna talk about micronutrients. They are almost always left till the end. And I wanted today to give a message that they are important. And the title of my talk will be Micronutrients in PICU, how critical it can be. Before I start, again, it's my honor and pleasure to be here. Thank you, Professor Tariq Abdelgawad. Thank you, Dr. Hanan. You have been so kind to invite me, and I hope this talk can answer the question. For those of you who do not know me, my name is May Nassar. I'm Professor of Pediatrics, and I am a consultant of Pediatric Clinical Nutrition and the director of the clinic. My agenda tonight will be just to define the micronutrients quickly and the subtypes, and then start talking about their importance in the PICU. I'm going to talk about some specific micronutrients, and then if we have time, I'm going to go through the micronutrients in the era of COVID-19. So to start with, the micronutrients, actually, they are vitamins and minerals which are needed in very small amounts by our body. If we want to compare vitamins and minerals, well, you all know that vitamins are complicated. They are organic and they contain carbon. On the other hand, minerals are just elements. They are found as such on the periodic table. When it comes to nature, vitamins are either fat or water soluble, while minerals are eaten in charged water soluble or sometimes in insoluble forms. As regards the source, vitamins are obtained from either plants or animals, but minerals are found in soil and rock. Vitamins can be destroyed easily by cooking and heat, while minerals are not vulnerable to heat or chemical reactions. Almost all vitamins are needed by the body to function properly, while not all minerals are needed. If you want to subdivide them, well, actually, micronutrients are 4 subtypes: the water-soluble vitamins, fat-soluble vitamins, macrominerals, as well as the trace minerals. Now, for the fat-soluble vitamins versus the water-soluble vitamins, you'll have to know that water-soluble vitamins, the B and the C, are absorbed directly into the blood, while the fat-soluble, which are the ADIC, ADE, and K, first goes into the lymph, and then the blood takes them. The transport of the water-soluble is freely, while the fat-soluble require protein carriers. The water-soluble gets stored. No, they don't. Those who get stored are the fat-soluble because they are associated with fat cells. For the excretion, the water-soluble gets excreted by the kidney and removed excess in urine, while the fat-soluble, well, actually, they are less readily excreted and tend to remain stored. Toxicity is recorded in the fat-soluble and possibly in some of the water-soluble. The requirements of fat-soluble should be on daily basis, while the fat-soluble can be taken weekly or monthly. Just to divide the minerals, we have the macro that are needed in 100 milligrams daily and above, and the micro or the trace that are needed in less than 100. The trace ones are the iron, zinc, copper, manganese, iodine, and selenium, while the macro are the calcium and sodium mainly. This is another classification where the minerals are classified by how much they weigh in our body. Those above 5 grams are listed in the top, and those below 5 grams, which are the trace, are listed below, starting by the R. Well, this table would show you all about minerals, the major functions, and the best foods. You'll have to know that the calcium and phosphorus are actually, they are the ones having the biggest RDR. It's like 1 gram. And both are needed by the bones and teeth and muscles, and they are found mainly in milk. Magnesium is needed in like half the amount, still needed by the bone and teeth, and found in leafy greens, vegetables. Iron, of course, is needed in like 10 to 20 milligrams daily, needed for hemoglobin synthesis, and there is the heme and non-heme sources. Zinc is needed like 15 milligrams and needed for wound healing, and it's found in meat, beans, and some nuts. Selenium is needed like 70 milligrams daily. It's an antioxidant and found also in poultry and nuts. Copper needed in like 2 milligrams per day, and it's needed for hemoglobin, collagen, and energy. Iodine, of course, it's the maestro of the thyroid gland, and the chromium is needed for blood sugar stabilization and fat and protein metabolism. Let's quickly just see this table, which shows us that nutrients can be either type 1 or type 2. Type 1 are functional nutrients, and all vitamins and most trace elements and calcium belong to this group. They are called functional nutrients. They have a body store. They get reduced with deficiency and have specific signs, but they do not cause gross failure. On the other hand, type 2, which contains most of the macronutrients, they are called the gross nutrients. And they do not have specific signs for deficiency. They just affect the growth. Let's now talk about the importance of the micronutrients in our life. They play a wide range of essential function. They maintain the body homeostasis. They serve as cofactors for many metabolic enzymes, regulate the gene transcription, and they power the body's defense against oxidative stress. This map would show you what a hidden hunger is. Actually, by definition, it's when the quality of food isn't well and micronutrients get deficient. And according to the map, we are in a state of like mild deficiency of these micronutrients. It's very important to know where we stand because we need to upgrade our position a little. Why is this? Because hidden hunger causes lots of problems. We have like 1 million child all over the world with deficiencies in micronutrients, especially vitamin A and zinc. And this is reflected on them. We get stunting in children, we get increased risk of diseases, we get impaired brain development. All this happens due to hidden hunger. What can we do? Well, actually, supplying micronutrients is by one of 3 methods. And I will talk about this later in details, but you'll have to know that food diversity and food fortification are preventive measures, while food supplementation, depending on dietary or nutritional supplements to provide the required micronutrients, is our last resort. Now let's talk about the emphasis about micronutrients in PICU. Critically ill are at high risk of developing micronutrient deficiency because most of them circulate in association with carrier proteins. These carrier proteins are reduced with acute inflammation and the body responds to physiologic stress. Determining micronutrient status in infants and children is further complicated given their immature organ function and specific metabolic needs. They are not like the others, they differ. Now, how about the feasibility of micronutrient assessment in PICU? Can we assess it easily? Well, actually, traditional markers used to assess micronutrients are unreliable in the critically ill. And their assessment is actually a challenge because of the illness severity, the nutritional status, the medication use, and the undesirable consequences of the medical and surgical interventions. Now let's talk about specific vitamins and what do we expect in PICU patients. If we start by vitamin A, we'll have to ask ourselves, is it really low? Because false low levels occur because there is low liver formation of retinol binding protein. Not to mention the vasodilatation and resulting leakage that may lead to the extravasation of this retinol-binding protein and other lipids into the extracellular compartment. And of course, the drop in circulating lipid levels that occur during inflammatory response can compromise the interpretation of all fat-soluble vitamins. Now, can vitamin E in critically ill be compromised? Yes, it can. And the duration of an inflammatory state would impair its status, because the deficiency due to inadequate nutrition occurs whether your patient is on parenteral or enteral route. The parenteral occurs because of the light-induced vitamin degradation and the adsorption via infusion lines. And for the enteral route, we have the malabsorption syndrome and bowel immaturity. And not to mention that those born to vitamin A deficient mothers are at a higher risk. And please remember that urinary excretion of retinol increases significantly in infection, and it might be equal to up to 50% of the RDA. So do we need to supplement vitamin A in PICU? Although vitamin A deficiency is associated with respiratory complications in the critically ill, actually, when they did a systematic review of 11 trials, they found that the supplementation gives only small benefit. And in older children, vitamin A supplementation for treatment of severe lower respiratory tract infection, it showed no benefit. Only the children, the ones who have severe measles, these are the ones who benefited from vitamin A in the literature. Let's now move to the maestro, the vitamin D. It boosts immunity, improves the mood, needed for a healthy heart, needed by athletes, can lower cancer risk, protect against asthma, prevent fractures, and of course, lower the blood pressure. Let's see. To interpret vitamin D in the critically ill, we should be cautious. And why is that? Because dysfunction of other organs like the parathyroid and the kidney may limit the conversion of 25-hydroxy vitamin D to the 1,25-dihydroxy vitamin D. And of course, the acute fluid loading can cause a hemodilution effect and lower the level of both of them. The unreliability of interpreting levels of plasma 25-hydroxy vitamin D in the critically ill is well known, and its level correlate with the CRP and albumin. Of course, critically ill children have lower levels of vitamin D binding protein compared to the general population, but actually this is a blessing in disguise because it will increase the level of bioavailable 25-hydroxy vitamin D. Now, for the vitamin D and critical illness, vitamin D level is low in the critically ill, and this is shown in too many studies in the USA and India. They found that nearly 40% of patients admitted to PICU have got low vitamin D levels, while in a multi-center study in Canada, this number was found to be 70%. So is it serious? Yes, because there is an association between low admission vitamin D and all the bad scores. It causes longer PICU, it causes severity of illness to increase, it also increases the need for vasopressors, and the mean duration of mechanical ventilation was reported to be high in those deficient in vitamin D. How about vitamin E? It's very well known because it is an antioxidant. So if we want to talk about it, we'll have to mention the oxidative stress and critical illness. Oxidative stress is associated with critical illness and related to the complication of multiple organ failure. And it's likely due to combination of factors like ischemia, perfusion injury, the systemic inflammatory response, the fluid shift in compartments, and also the other physiologic responses. So what does vitamin E do? Actually, this is vitamin E. It stops the chain reaction by changing the nature of the free radical. So it does save us, and it's a very well-known antioxidant. So should we just go and supplement it? Actually, its status, all the studies evaluating its status are currently lacking. And we still need further studies. And even its levels, it can be misinterpreted because of the lipid carriers. So vitamin E role in modulating oxidative damage during critical illness needs actually further explanation. The last one of the fat-soluble vitamins, which is the vitamin K, actually vitamin K is needed for too many functions in our bodies, including the bone metabolism. And in critically ill, we'll have to mention that the prolonged PT and hypoproteinuria that happens with antibiotic use, especially the cephalosporins, by the direct inhibitory effect on gamma carboxylation of the vitamin K-dependent clotting factors, or by the disruption of the intestinal flora that accounts for menaquinone production. The effect of antibiotics on vitamin K status in the critically ill is most evident if the baby or the child is malnourished or if the antibiotic use is prolonged. In spite of all this, prophylactic administration of vitamin K in this population does not seem to prevent the development of hypoprothrombinemia. And now for the water-soluble vitamin, we have the B and the C. B in the critically ill can get compromised. Remember, we have a hypermetabolic state, we have decreased intestinal absorption, insufficient intake, high excretion, drug-related fluctuation, underlying metabolic disease. And remember that due to the complex cellular and biochemical mechanism involving vitamin D and the imbalances that occur, functional assays for the vitamin and indirect measurements for these vitamins may not be as accurate as one can expect. How about vitamin C? Vitamin C in the critically ill, while interpreting its level is also difficult. And despite being an important factor in the body's defense against oxidative stress, the difficulty in measuring its concentration and interpreting the changes leaves us also without a decision. However, most of the researchers supplement vitamin C and give it because it supports the microcirculatory changes and the immune function. If we go now for the trace elements, just to tell you quickly that the iron is above all. The iron is very well known in critical illness. Actually, there is a defense mechanism in the body against invading organisms by limiting the iron utilization. And this is done via the hepcidin. Hepcidin is the master regulator for iron metabolism. And we get the anemia of inflammation with high hepcidin and rise in ferritin level. Iron level in PICUs, well, actually there is inverse correlation between its level and the pediatric risk of mortality in PICU. And too many researchers found that almost 3/4 of the patients in PICU are anemic and require transfusion. And if they take transfusion, well, this theoretically can contribute to the increased oxidative injury because of the non-transferrin bound iron. How about zinc? Zinc in the critically ill, actually acute inflammation decreases zinc by inducing its redistribution. In addition to systemic inflammation, failure to meet the recommendations by dietary intake also causes low serum zinc. And there is dysregulation of many genes involved in its homeostasis. And it is correlated with the lymphopenia as well. They tried zinc supplementation, but it did not give the results that it should have. As for the selenium, in the critically ill, serum selenium levels decrease with systemic inflammation. And in the critically ill, assessment has to take into account both the degree of inflammation and the nutritional status. For the low selenium or an increased fraction of reduced glutathione, these have been associated with increased incidence of multi-organ failure. Supplementation of critically ill with zinc and selenium as a part of a very large preventive trial, unfortunately, did not find an advantage in reducing the rate of nosocomial infection. Copper is the last one we're going to talk about, and actually, copper rise in face of systemic inflammation because ceruloplasmin is a positive acute phase reactant. And the reduction of hepatobiliary flow contributes also to its increased level. Now, to conclude this part, assessment of micronutrient status in children is challenging due to age-dependent metabolic demands. Plasma or serum levels of micronutrients rarely reflect the total body store. Functional assessment can help, as long-term micronutrient deficiency can lead to serious consequences. Recommendations for their supplementation should be highlighted. Now, this is a very interesting paper published in April 2020. They say that during critical illness, micronutrients should be provided in sufficient amounts to meet the reference nutrient intake. Although there is insufficient data to recommend routine supplementation, they mentioned a very nice sentence. They said the absence of evidence should not imply evidence of absence. And when scientific studies are urgently needed to investigate hidden hunger in order to get a result. In order to prevent hidden hunger, we have to resort to food diversity and fortification. And remember, supplementation is needed only if these two cannot be ensured. How to do that? Actually, our vision for food security, which is shown in front of you, should include everything concerning food justice, social justice, just to support small industries, support the farmers, and make sure that everybody got the right to nutrition, good nutrition for all. Now, I'll have just 3 minutes to give you something about micronutrients in COVID era and tell you that vitamin C, D, and zinc gained much attention, and everybody was talking about them. Actually, they made some clinical trials, and one of them was with vitamin C, and it was in Wuhan, and they started giving people huge doses, like 10 to 20 grams per day. They did not publish anything up till now. Vitamin D trials was a little modest. They gave only 25,000 international units single dose, and they are looking how would it help. For the zinc, because it's the only one of the micronutrients that has got actual antiviral activity in the hypothesis of how it makes us immune against COVID, is gaining much attention, but the dose should not exceed 20 to 50 milligrams daily. Just to give you a take-home message, please remember that micronutrients are our allies. We need to keep them in the right place with the right amount. If the human body is forced into a war against microorganisms, the best immune status is guaranteed by the optimum micronutrient level of the body. Preventing hidden hunger should be a national concern, since replenishing the deficits in critical times is very hard. Food diversity and fortification are the best preventive strategies for hidden hunger, and supplementation is resorted to only if these two are not feasible. So we do not have to give heroic doses. We do not have to put ourselves in a situation where we are deficient and going into critical illness. Please try to combat the hidden hunger. Try to make all the population have enough micronutrients for the immune system, just in case they suffer any infection or go into any critical illness. You will only need the RDA and a little much above it, and this will be all to ensure your body to be facing this infection in the best immune status. These are my references, and I hope I'm on time. Thank you very much, and I'm ready for any questions.
Thank you, dear Professor May, for this actually marvelous talk about hidden hunger and these important trace elements in ICU. And of course, it was very fruitful meal from